Good afternoon, everyone. We're going to get started. Let me first say welcome to today's meeting. We have a fairly light agenda in length, but meaty agenda, so I want to go ahead and get started. We'll start with introductions, starting to my right.
Good afternoon. I am Christine Smith, Clerk to the Board. Welcome.
Good afternoon. I am Arlissa Easton, Deputy Clerk to the Board.
Hello, I'm Susan Rodriguez McDowell, elected by the people of District 6.
Good afternoon. I'm Laura Meyer, and I represent District 5.
Good afternoon. I'm George Dunlap, elected by the people of District 3.
Good afternoon. My name is Lee Altman, County Commissioner serving at large, and I have the privilege of also serving as Vice Chair. Welcome.
Good afternoon again, everyone, and welcome. My name is Mark Jarrell. I've been elected by the people of District 4. Also have the honor of serving as Chair of the Board.
Good afternoon. The name is Vilma D. Leak, and I represent the most powerful people in the district. That's District 2. And I'm grateful that they have selected me as their representative.
Good afternoon and welcome. My name is Arthur Griffin, and I have the pleasure of serving as County Commissioner at large.
Good afternoon. I am Commissioner Elaine Powell, representing District 1, which is North Mecklenburg, Huntersville, Davidson, Cornelius, and North Charlotte. Welcome.
Good afternoon and welcome, everyone. My name is Commissioner Yvette Townsend Ingram. I also go by Commissioner YTI. Thank you. Welcome. I serve you at large. Sorry.
Good afternoon, Tyrone Wade, County Attorney.
Good afternoon. Welcome. Mike Bryant, Mecklenburg County Manager.
We'll hear from the executive team.
Dr. Kim Campbell, Deputy County Manager.
Good afternoon, Leslie Johnson, Deputy County Manager.
Good afternoon, Michelle Atreed, Deputy County Manager.
Good afternoon, Derek Ramos, Deputy County Manager and Chief of Staff.
Anybody else?
Good afternoon, Adrian Cox, County Budget Director.
Good afternoon, Michael Griswold, Director of Strategy and Innovation.
Good afternoon, Bernard Washington, Public Health Director.
Thank you. Is that?
Good afternoon, Suzette Nudrick,
All right.
Jennifer Patterson, Senior Associate County Attorney.
Jerry Michael, my manager in Environmental Health.
Crystal Swinger, Director of Environmental Health.
Stephen Miller, manager of Environmental Health.
Rosario Chico, Assistant Health Director, Maternal and Child Health.
Sonia Smith, Assistant to the Health Director.
Yeah, they're all staff.
Thank you.
All right. Thank you, everyone. If you will stand and join me for the Pledge of Allegiance. I pledge allegiance
To the flag of the United States of America, and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
All right, before we start out with, before I throw it to the manager, there are two things I want to take care of. The first thing is always, we level set our meetings by going through our mission, our vision, and our board priorities to help navigate our discussions. Our mission is to serve Mecklenburg County residents by helping improve their lives and community. Our vision is Mecklenburg County will be a community of pride and choice for people to live, learn, work, and recreate. Our FY 26-27 board budget priorities are economic development, education, environmental stewardship, health equity and wellness, services for seniors, workforce development, and reducing racial disparities. Mr. Manager, before I turn it over to you, I do want to give a special shout out today to the women of Delta Sigma Theta Sorority Incorporated, and I do want to say Happy Founders Day to all of you that are represented here today, including Commissioner Leak, Dr. Johnson, and Dr. Campbell. And we have others. We got everybody here. So if you listen, have ladies of Delta Sigma Theta Sorority Incorporated, if you will please stand and be recognized on your Founders Day.
Yay.
Wow.
didn't just join last night either.
You're not paper members? Okay, all right.
That's right.
Appreciate y'all. All right, glad we got that out of the way. Mr. Manager, why don't we turn it over to you,
Yes, sir, it's my pleasure. Thank you for doing that, Mr. Chair. You have 2 items on your agenda for this afternoon, and both items are aligned to your health, equity, and wellness priority. And also, both items will be covered by Dr. Washington, the Director of our Public Health Department. For this first agenda topic, he's going to provide you an update on the state of the county's health. And I'm going to ask, Mr. Chair, that you recognize Dr. Washington come forward and deliver that presentation to you at this time.
Dr. Washington is recognized. Thank you.
All right, good afternoon, everyone. Chair Jarrell, Vice Chair Altman, County Manager, Commissioners, thank you all for the opportunity. You will all remember, once a year I come and talk for a long time about things I must talk about, but really important updates relative to the health of our county and also requirements for your function as the county's Board of Health. So I will do 3 things today. As the managers mentioned, this first one really is an update on the state of the county's health. It's 2 sections, one really thinking about the overall health of the county, and the second section is a communicable disease update, which both are required by statute for accreditation. And then secondly, I will be discussing some proposed amendments to our Board of Health rules that I'm only here to discuss today, to explain them to you all, what the changes are. And then we will be actually putting them on your regular meeting agenda for consideration for approval, and I'll talk about the process as we get to that. So I'm going to try to get through this as efficiently as possible. It is quite a bit of content, but I will try to, I think we'll take questions after the first half, and then I will come to the Board of Health Board of Health rules thereafter. All right, as you all know, every year we publish a State of the County Health Report. It is not just a requirement, but it really is an important thing that we do to ensure that residents, our partners, and others in the community who care about how healthy we are and where we're making progress understand the where we're making progress, where we still have opportunities, and specifically as it relates to the things that we say we're trying to improve, are we getting towards the goals that we've outlined? The State of the County Health Report includes more than 50 indicators across a variety of different crosstabs, and lots of data are in the report similar to our community health assessment. I will just highlight some of the key areas today with some metrics associated with each one of our 5 Live Well priorities. Just as a snapshot, you guys have seen this before, you know, sort of our community continues to grow. And as our community grows, it is obviously great for us, both economically, diversity, and the vibrancy of Mecklenburg County. But with that also comes new challenges as it relates to health and ensuring that we have a health system, a public health system that can support the growing and more diverse community that we serve. This next slide is our leading causes of death. This doesn't change very much. The biggest change we've ever had to this was when the COVID pandemic was happening, because COVID was not a thing, and then it became the 3rd leading cause of death. It, of course, now is not causing that kind of mortality, so you don't see it here. And the vast majority of the leading causes of death in Mecklenburg County continue to be chronic diseases. Every year, we sort of have this back and forth between cancer and heart disease, one of the 2 being the leading cause of death. For the most recent year of data, 2023, cancer was the leading cause of death. But that does go back and forth, as I said, every year. Unfortunately, vital statistics do take a long time to close out, and so you will see some changing dates in even this report, and as always, because the vital statistics typically take anywhere between 12 to 24 months to be finalized after the year has closed. All right, just to remind folks, as a part of our community health assessment and community health improvement plan, there are 5 priorities: access to care, chronic disease prevention, mental health, violence prevention, and maternal and infant health. I will talk a little bit about where we are in each of these areas at a high level, speaking to some of the indicators, and then we'll transition over to just talking a little bit about where we are with the community health assessment process overall. All right, up first is access to care. This is where I think we have some really positive news, and I think you all have heard me talk about this before publicly, and look forward to, at the upcoming budget retreat, having a more in-depth discussion about the progress we've made on access to care and where we still have opportunities. But as we've seen over the last couple of years, insurance coverage in the county is improving. So more people have insurance, largely because of Medicaid expansion that happened here in the state. And so we estimate that in 2024, about 8%, 7.5%, roughly, percent of adults will have coverage. That number does fluctuate. That's an estimate right now. We haven't gotten the final estimates from the census, and so you see that sort of confidence interval there, because we think it'll be somewhere between 6 and 9% of folks with coverage. That does put us sort of right where we want to be in terms of our goal for 2030 as it relates to how many residents in our community don't have insurance. And so again, as we all know, Medicaid expansion was highly consequential for us as a community. Of course, there are concerns about where that looks in the future, but this is just a testament to why that policy is so important and the value that it has for us as a community. Other indicators that we track in terms of access to care are the percent of our residents who don't have a primary care doctor. And over the last 5 years, we've actually seen improvements in the number of folks who are reporting that they don't have a doctor. And so that's gone down from 28% in 2018 to just above 22% in 2023. We still are quite a bit of ways from our goal of 16%, but the progress is certainly noteworthy. And we would expect that that will continue to get better as folks are, of course, getting health care coverage. Now, this will certainly change if folks don't have access to health care coverage. The last indicator in this space is related to residents who are reporting on our household survey that they are not seeking care or getting primary care because they don't have cost. Because they can't afford it, where cost is a barrier. And so, again, similar story, and I would say good news, a consistent decline in the number of residents who are reporting they can't access care due to cost. And we have actually hit the 14% threshold that we set for ourselves. And so, again, this is, I would say, good news that residents have better coverage. More people have a primary care doctor, and fewer people are saying, I can't get health care because of cost. That said, we still have, obviously, people who can't get health care because of cost, and so there's still opportunity. I'm not saying the work is done, but certainly it's positive. It's encouraging to see some progress here. But of course, I will reiterate the concerns around potential threats to that. Next up is chronic disease prevention. So one of the key areas that we haven't been able to spend as much time talking about because of all the things happening in public health right now is chronic disease prevention. But it is important to also recognize that smoking still continues to be the leading cause of preventable death in this country. And so smoking causes both heart disease and all types of cancers. And so it is still really, really important that we continue to emphasize the importance of folks not smoking. And so we have a number of efforts that are focused on both policies, but also making sure folks have alternatives to smoking, meaning that they can, cessation programs, trying to keep our youth from smoking in the first place. And so we have seen progress in adult smoking over the last decade, where that number used to be much closer to 20%, and it's now declined close to 10%. But we really do need to get that number further down. And so we will continue carrying this message of tobacco prevention is a key component of us improving life expectancy for our community. All right, shifting gears, again, I told you I'm going to sort of touch topics at a high level, and I'm happy to talk more about issues during the discussion section here. But in the mental health space, again, some good news, I would say. On the mental health front, we have seen a decline in our opioid overdoses. This is, as of 2024, we did see probably our steepest improvements yet after many years of really sharp increases in opioid overdoses. I will caution that this is still a work in progress. It's still too many lives being lost due to opioid overdoses. So this is not, again, we've won. This is just we're making good progress. And we do know, at least from preliminary data, that this number has gone up a little bit in 2025. And so we still have much work to do to continue to combat the opioid epidemic, as well as making sure that we are instituting as much resource around harm reduction, as well as substance use treatment in the community. And so while we're making improvements here, it's not the time to take our foot off the gas. Also emerging in this space is issues around equity, where we are seeing growing, increasing rates in our Black and Brown community, and lots of this improvement that we see is actually in the non-Hispanic white community, and so we have shifted with a lot of focus in the last couple of years to ensure that our providers who are doing harm reduction work are also are reaching out to our Black and Brown communities and ensuring that we are getting resources and naloxone and other types of supports to those folks to avoid overdoses. On the mental health front, as I think everybody in this room is aware, we continue to see more adults reporting mental distress, as well as more high utilization of our healthcare facilities for behavioral health services. And so, again, continues to be a challenge for us, not just for adults, but also for young people. This is a self-reported assessment on our household survey, where we do still see increasing rates of adults who are reporting not having good mental health days on a monthly basis. And so that number is getting worse and remains an opportunity for us. And I think this is important because it's not just about folks with diagnosed mental health conditions. These are, adults who are just saying, I'm experiencing mental distress. And so that, of course, is just a signal for what is happening in the broader community as it relates to not just diagnosed mental health conditions, but just overall distress for residents. And so it is important that we continue to have clear focus on behavioral health services, both low acuity and high acuity. Last year, we talked quite a bit during this report about youth suicide attempts, and so we have at least flattened the curve a bit. We were accelerating, I would say, for several years, and you can see clearly here where we had a lot of kids in the emergency departments with suicide ideation. And so that has improved in that we haven't seen the kind of growth that we were seeing for several years, and we're starting to see some declines. But as you can see, that number is still incredibly high in terms of how many kids are showing up in our ERs with mental distress to the point of suicide ideation, further just emphasizing the importance that we continue to focus on mental health for our young people. All right, last topic here is maternal and child health. Our infant mortality rate as a community actually continues to be better than the state and really the national average. The big story as it relates to infant mortality is that we've seen improvements consistently over the last decade, and that is actually really good news. However, we continue to see this disparity for Black babies in our Mecklenburg County, as we do see in many communities across the country, where Black babies are dying 3.5 times more than other races. And this is basically kids not making it to their first year of life. And so the need to close this gap. And while we've seen some improvements in the Black community, as you can see from just looking at the last 10 years of data, the gap is not really getting any smaller. And so we have work to do here, which is certainly why the emphasis on the prenatal to 5 work continues to be a huge priority for us as a community, not just the county, but our broader stakeholders, our healthcare systems, to ensure that we're protecting kids when they're in the most vulnerable stages of their life. All right, so to summarize all of what I just said, some improvements, certainly, but some opportunities. We certainly are seeing improvements in opioid overdoses. It's great to see the improvements around insurance coverages and the persistence disparities that we're experiencing as it relates to maternal and child health, as well as mental health, remain big opportunities for our community in terms of health improvement. We are launching, as you all know, we're in the community health assessment process and shifting into the community health planning process, which is the 3-year cycle that we do with our health systems. This year, the steering committee that includes our hospital systems has devised a plan to sort of launch a Live Well tour to bring our residents closer to this work and create opportunities for residents to continue to be a part of the process, not just when we're doing the data collection, but also as the hospitals and us are developing these improvement plans. And really ensures that our residents get to some say, and also brings us an opportunity to work together to bring some resources to folks in our community. So they will not just be opportunities for engagement, but also we'll have partners and our teams available to deliver resources. And so the tour will launch this spring. We've identified 7 locations in the entire county, covering all sides of the county. And you can see those listed here where they'll be located. All of our hospitals will be represented, as well as the steering committee. We welcome each of you to join as well for any of the tours you want to participate in. and the dates and times and locations will be shared with you all later, but just wanted to give you a heads up that this is coming, and they will start in February and run through the month of April. We will, Dr. Scott and the team will share more coming up. So next up in the overall process, and this will wrap up sort of the Livewell update for today, is that we will release the community health assessment ahead of time in March of 2026. We'll have the tour from February to April, and then we will have the final convening of our partners in June of 2026. And then from there, we will complete the 2026-2028 Community Health Improvement Plan in July. That plan will accompany not just the sort of improvement plan, which is our response strategies, but as required by the state, it will also have the Clear Impact Scorecard that goes along with the plan that has our metrics that we're measuring at the community level, but also has the actions that we're taking that will be able to track over time what our targets are for the next 3 years. And so it'll be a busy few months leading up until that point, but we'll bring the Community Health Improvement Plan back to you guys as well when that time comes. Okay, I have to shift to another presentation on communicable disease, and then after this we can take some questions. I'll put this in. Uh-oh. That's it? Okay, all right. I don't know. Okay, I think that's good enough. I can make it work. Okay. Thank you. All right. So you notice I didn't talk much about infectious diseases. So separate now is our CD update for the year. So as you all know, we track communicable diseases. We respond to communicable diseases. We have a long list of reportable conditions that are outlined for us in the administrative code that are reportable to the health department. They are organized into several categories. I won't go through the details. You receive a CD report on a monthly basis. It's posted to our website, again, as required. The 6 big categories are sexually transmitted infections and bloodborne pathogens, enteric, foodborne, and waterborne illnesses, vaccine-preventable diseases, contact and respiratory diseases, vector-borne and zoonotic infections, and then the last bucket includes encephalitis, meningitis, and prion. So those are the buckets. I won't talk about all of them today, but I will hit on some highlights of the most significant things that we've observed over the last year in terms of communicable disease activity. We also track 6 biological agents to ensure that we don't have any potential biological activity happening in the community that might pose a threat to national security. Thankfully, we don't get any reports of these very often, so if we did, you guys would know. So not much to share there. Okay, most of the diseases that we are on the list of diseases that we track, we don't get a lot of cases of, so that's the good news. But there are some that make up a large share of what we have to investigate. The enteric, foodborne, and waterborne illnesses and the sexually transmitted infections are the ones that we get the most volumes from that require the most work of our communicable disease team. All right, so just in terms of big things to note, we are seeing, as you've heard me discuss, a resurgence of vaccine-preventable diseases, not just here in Mecklenburg or North Carolina, but across the country. This map that's here shows you the MMR vaccine coverage for kindergartners in the 2024 to 2025 school year. And you can see that there's a lot of variation across the country. The lighter colored states are where you have the lowest vaccination rates, and the darker colored states are where you have the highest vaccination rates. And the unfortunate thing is that many of those states, particularly the lighter colored states, at the statewide level are well below the threshold, our desired threshold for herd immunity, which is about 95%. North Carolina is hovering around 94.2%, which is lower than it has been. That number has declined over the last decade. Mecklenburg County is around 91 to 92% for our kids in school here. Again, our target is 95% is the level that we want to ensure that we have the best level of protection. And so that number declining is certainly concerning. There's two reasons why it's declining. The first one, of course, I think everyone's aware of, and that is the ongoing sort of vaccine hesitancy and misinformation that continues to challenge us in public health and in medicine altogether. And so we are seeing a growing number of families who are requesting exemptions from being able to adhere to CMS's requirements for vaccines. That number is growing. It's grown to well over 5,000 at this point. And so that growth is certainly concerning for us because it does create more opportunity in our school system for these kinds of outbreaks like we see what's happening right now with measles in South Carolina, which I'll get to in a second. And so I do want to keep into focus, though, that is still a very small number of kids relative to the total number of kids that we have in schools. And most families are compliant, and most families don't believe that vaccines are harmful. And so I don't want to underscore that we are largely our families are doing the right thing and getting their kids vaccinated. But the fact that the number of folks who are not is growing is concerning. If that growth continues at some point, then we're going to end up with way too many kids who are not vaccinated, and it will make it very easy for pathogens to make their way around our schools. And so it is something that we have to continue to stay focused on and have to work towards ensuring that we answer questions and that we counter false information, counter narratives, and really work not just with our parents, but with our provider community to make sure that they are equipped to answer questions. Our school nurses are on the front lines of this every single day. I can't say enough how critical of a role they're playing in the work to make sure our kids are vaccinated. The second group is folks who just haven't done it. They haven't either prioritized or made the time to get it done. They haven't requested an exemption from us. They don't necessarily not believe in vaccines. They just haven't prioritized or been able to get it done, or they have access issues. They don't know where to go. They haven't been able to get an appointment at their child's pediatrician. So that group is the group that we have the greatest opportunity to quickly close the gap, to get back up above 95%, which is why we have programs like Mech Health in Action, which is the mobile health program, which goes on site to the schools that have the lowest vaccination rates. We literally focus on those schools to set up clinics, and the mobile unit goes out, gets consent from parents, and vaccinates on site at school, because the school nurses know exactly who's not vaccinated. So we're uniquely positioned to do that. And so that's an important part of of what's emerging. We're also seeing a growing cases of pertussis, which is whooping cough. We're seeing more cases of varicella, and I'll get to some of that in a second. But to get to measles, which is sort of the hot topic this week, because as you all know, over the weekend we did detect measles in the wastewater here in one of our watersheds. We still routinely test our wastewater in the county for various infections. Typically when we have a wastewater detection, we normally have a case that we know about. In this case, we don't have a case that we know about, and so we don't know where the detection came from. And wastewater surveillance does not allow us to narrow down to a street, a block, a house, or a person. It's just literally like 100,000 households waste water in one pot, and we take samples out of it. Probably not the best description of this, but you guys know what I'm talking about. But anyway, so it is concerning. A couple scenarios could explain it. One, there's a case that we don't know about that's here, which is, I think, the most concerning scenario. The second is we do know what's happening in South Carolina. They added 99 cases last week, and it's in their update, which is acceleration of the outbreak. It's not getting better. So it's possible a South Carolina resident with measles was here visiting. We do know that we've had some in the county. There's also possible that there was a patient at one of the healthcare providers who had measles that came here for treatment and lives in another county. A couple scenarios could be causing it. We don't know exactly what it is, and we can't pinpoint it, but we are watching closely. This week, our team worked quickly over the weekend, actually, to go ahead and mobilize some activity to make sure that we were trying to ready our residents as much as possible. We have been communicating since the South Carolina outbreak began, but we did open up our immunization clinics to allow walk-ins. So any parent in the county who needs to get their kid vaccinated can just walk into any of our 4 sites without an appointment, and we're offering same-day service to just make this more convenient. I do think it's really, I think as we said early on, it's just a matter of time. It's here. There was a case in Gaston County. the situation in South Carolina does not seem to be getting better. And so the longer it carries on, the more likely there'll be a case in Mecklenburg County. Our team is well prepared to respond to it. We have measles tabletop exercises. Our health systems and partners are prepared to respond. I wish we didn't have to, because we have tools to help us from having to respond to this. But here we are anyway. So we are prepared and equipped to do so as needed. But as you can see, the measles situation in the U.S. is getting worse, right? You know, we had more than 2,000 cases last year. And as an example, in South Carolina, more than 95% of the folks with measles are not vaccinated. And so I think the data are very clear. It's not really something you can argue with, that the tool that we have works. Folks just have to take advantage of it. All right. I've jumped ahead a little bit to skip some of my slides, but you guys kind of get the story. Happy to answer any more questions about measles or pertussis or whooping cough. But we continue to see growth and, again, are trying to respond as best possible. It is also respiratory viral season. We are currently in the very high category, both in Mecklenburg, in North Carolina, and across the country for flu activity. COVID activity is actually pretty minimal right now. We are seeing increasing levels of RSV, but the big concern right now is the flu. So we do have quite a few folks in the hospital who are sick with the flu. Both of our hospitals have activated their sort of flu season protocols, so they're minimizing traffic in the hospital, minimizing visitors, and it does seem that the flu severity is a little worse for some folks, and so it certainly is. There's still time to get your flu shot if you haven't already, sort of my message to folks. And again, as we've always said since, the beginning of time, if you're sick, just stay away from everybody else. It's sort of a simple message, and so we continue to try to get that message out into the community. As I mentioned just now, our hospitals are really busy. So if you got to go to the hospital right now, I suggest you put on a mask, because it's a lot of activity, a lot of sick people there. So. We haven't had any pediatric deaths yet in Mecklenburg County. We have had 4 deaths among our residents due to flu as of the first week of January. And again, that number will continue to rise as the flu season moves forward. All right, so that's it on respiratory viruses. Just quickly want to talk about two more areas of things that we're watching closely in the health department. The first one is Legionella. We have definitely seen an increase of Legionella here in the community. It's a serious type of pneumonia. We don't have any evidence yet connecting any of the cases or finding any kind of common sources. So it's something that we just continue to watch very closely, that as a part of your annual update, I wanted to flag for you. And then towards the end of last year, we started to see a slight uptick in our Mpox cases. And so, again, we were able to sort of contain the outbreak that occurred in 2022. We saw just a little bit of an uptick towards the end of last year, so we are watching that very closely. The immunization clinic and our HIV STI team continues its efforts to vaccinate the most high-risk folks. Most of our cases are sexually transmitted, and so we are focusing as well on that. All right, shifting gears now to HIV and AIDS. HIV continues to be an appreciable source of morbidity for our residents in Mecklenburg County. We are making progress. It is just slow, as you would expect with something like HIV that is doesn't have a lot of symptoms or can be asymptomatic for a very long time. We are currently seeing, I would say, a leveling off of new HIV cases, which is progress, in that we're not seeing the kind of growth that we saw a decade ago, where this line would have been just a straight line up. But it is coming down over the last decade slowly, and so we are continuing our work to make sure that, one, we have adequate testing in the community, which our community partners are doing a fantastic job at really being the boots on the ground for us and making testing available. And I can't speak enough about how critical those partnerships are. Making sure that we have access points for HIV PrEP in the community, which thanks to you all support, we're able to do that to make sure that folks, whether you have insurance coverage or not, have HIV PrEP. And then again, our team at the health department is really working to make sure we link people living with HIV to care and keep them in care. And that work is so critical, because if folks are able to get virally suppressed, they can't transmit the virus. And so that helps us in our effort to reduce transmission in Mecklenburg County. The demographics of our HIV cases continues to look the same as well. So clear disparities for our young African-American men, which is why a lot of our work focuses specifically on that demographic, and also is why that those relationships with our community partners is so critical in our work to meet people where they are. We have to make testing available wherever people are, whether it's a nightclub or it's a shopping mall or a grocery store. Making it available where people are is really, really critical. And so we will continue to do that work as well. All right, a little bit more news on STIs, and then we'll wrap up this section. STIs continue to be way too high in this country, and we have started to see, though, some progress in other STIs outside of HIV, and so I did want to talk a little bit about those. We are seeing still way too many STIs compared to where we were, let's say, a decade ago, but the improvements are somewhat encouraging. And then the last bullet here speaks to congenital syphilis, which I'll get to in just a second. As you can see from this chart, the rate of syphilis infections in our community and across the state have risen significantly over the last decade. We are starting to see some progress on syphilis infections where that growth is starting to slow down, which again, when we talk about infectious diseases, just slowing the growth is the first step. If the number keeps going up like you see with the measles outbreak in South Carolina, then you get really worried that you're not making any progress. But when you start to flatten the curve is certainly encouraging that what you're doing is right, but it also means you have to keep doing it. You can't claim success. So again, some minimal progress on syphilis here in Mecklenburg. Similar patterns are being seen across the state. As I talked to you guys last year about congenital syphilis, which is, of course, syphilis passed from mom to baby, we launched a congenital syphilis, HIV syphilis task force led by Dr. Johnson, who's here. And that team has worked alongside our healthcare providers, our internal teams, to really ensure that we were covering all of our bases when it came to congenital syphilis and finding every pregnant woman to make sure that our providers were complying not just with the law to test women, but also were properly treating women. Many of the cases that we had of congenital syphilis were due to women who knew they had syphilis, but did not receive the proper or adequate treatment when they went to their healthcare provider. And so we launched the Syphilis Summit a couple of years ago to educate providers who may not have been up to date on the latest science about how to treat syphilis, to make sure they were giving pregnant women the appropriate dosage of Bacillin and the appropriate number of injections. And that summit has been highly successful, so much that it's now regionalized, and we have folks from other counties who are joining us because there isn't anything else like it in the state, where we're literally making sure that our provider community are up to date on how to treat syphilis and ensuring that people are getting complete syphilis. I can't say enough about our case management team and the health department, who have also sort of jumped in to make sure that they're literally chasing pregnant women down to make sure that they, one, get tested, but two, if we find a pregnant woman with syphilis, that we do everything possible to get her to get treated. And that's one of the big challenges and barriers is getting folks to get into a doctor's office and get treated. And our case managers have done a fantastic job of doing that. And as a result, we've seen progress. So in 2024, we had 23 cases of congenital syphilis in Mecklenburg County. And just as of September of last year, there were only 10 cases. And so that kind of improvement over just a year really is a testament of not just focus on this issue, but the amount of work that's happened in the health department and with our healthcare systems and the providers. I'm very proud of the work that they've done. We have some threats, though. I mean, essentially, the medicine that we use to treat syphilis in pregnant women has been experiencing a national shortage for quite some time. We keep going through these lulls of having medication and not having an adequate supply. Right now, we're in a lull where we have inadequate supply. And so we are having to basically manage the inventory that we have with a very close eye. And so as that continues, the pharmaceutical companies are working to produce more, but of course, if we don't have the medication to treat, then that will put us in a difficult position. Also, a bit of good news on chlamydia and gonorrhea, which are the most common STIs that we deal with in the county, and again, disproportionately impact our young population. We are seeing some improvements, again, as similar to national trends, where these numbers are starting to come down in the number of cases of chlamydia and gonorrhea that are being diagnosed here in Mecklenburg County. Still way too much. But again, seeing this curve sort of bend the other way, I would say is actually good news for us as a community. And Chairman, that is it for my health update.
Thank you, Dr. Washington. We will start it off. I'm going to start with the chair of HHS, Commissioner Griffin, then go to Commissioner Meyer, and then Powell.
Thank you, Mr. Chairman. First of all, Dr. Washington, thank you to you and your team for doing a phenomenal job in collecting and sharing and informing and educating us on the health of our residents here in Mecklenburg County. So share that with the entire team that Chairman Arthur Griffin said. Thank you.
Yes, sir.
The other piece is to recognize the members of the HHS committee, Commissioner Powell, Commissioner Lee, Commissioner Vice Chair Altman, and myself. We get information on a regular basis, and certainly this is a continuation of trying to share with the general public the state of health here in Mecklenburg County. A couple of things that I want to sort of highlight, and one is Dr. Washington so carefully indicated that in March of 2026, we'd have a community impact scorecard. He said that so fast and so quickly, although it's a state requirement. It is something that's absolutely critical from my perspective in terms of those programs that are doing well that we can highlight. And it will be the first dashboard with the impact scorecard that we've had in Mecklenburg County. Is that correct?
Second, but yes.
All right, which I think is really important. So I call it transformative. Dr. Washington says it's state law, but it's still good practice. The other piece I want to try to highlight is the utilization piece. We have a number of residents thankful to the General Assembly and all the work of everyone who participated in getting more people on Medicaid. It's utilization. You probably heard Dr. Washington say on several occasions, trying to get people in for treatment or some evaluation. Hopefully in the future we can look at utilization. Mr. Chairman, you raised something more than a year ago when teenagers were concerned about getting athletic physicals. The number of young kids who are in households who are eligible for Medicaid could get those things taken care of without that last-minute crush on health facilities. So I'd like to see at some point, and Dr. Washington and I have been having this conversation, some indications about utilization of people getting annual checkups, et cetera. And he's also said how important it is for this measles epidemic that we are experiencing for young kids to get their immunization shots and all of their appropriate shots at an early age. So utilization is quite important. And I'd like to reiterate what Dr. Washington said about school nurses. The news certainly is on measles right now, but the fact that Mecklenburg County is supportive of school nurses and additional health care specialists in working with our students is so critically important in addressing not only measles but other childhood diseases. So thank you, Mr. Chairman.
Thank you. Commissioner Meyer.
Thank you. Thank you so much, Raynard. I appreciate it. I have a lot of questions, so I'm going to just say them because I only have 3 minutes. The teen suicide rate, is there a way you can give an estimate on how many, like, actual kids are going to the ER? And then, do you stay in touch with the schools, including private schools, and how are you getting the statistics? Are they just ER reports? And then vaccinations, I thought they really could not go to school at a certain point if they were not vaccinated. So are these kids who are, you're granting exceptions or exemptions, and you said 5,000 total, right, are not vaccinated right now? How many of those are exemptions? And then the syphilis medication, why is there a low inventory? Is that typical? Is this like over the years, or is this like something new?
Yeah. All right. So I'll take those back from the top. Happy to get you the counts on teen suicides as well as the overall ED visits for youth behavioral health issues. The team will get that for you. So the way that we do keep in touch with the schools, we don't have as much information about private and charter schools. One of the tools that we use, so for the ER data, that comes from hospital surveillance data. So we have syndromic surveillance. So when people use the ER, we're able to see on a weekly basis why folks in the county are going to the ER, and we have minimal demographic information about them. And then we also have the Youth Behavioral Risk Factor Survey, which has been a really valuable tool for us to be able to understand in public schools. It's a survey of students in public schools to understand their health behaviors. So are they thinking about suicide? Are they depressed? Are they using substances? Do they smoke? All those kinds of data points is really critical. There's been some disruptions in the YRBS with the new administration, and so we don't have, there are concerns about whether we'll be able to actually have that data source, which is really important on a long-term basis because of changes at the CDC. But that doesn't include private schools. That focuses on public schools. It's a sample of classrooms from public schools, so not as much about what's happening at private schools. The way the vaccine policy works for public schools in North Carolina is essentially the students are required by law to be vaccinated by the 30th day of school. And if a child is not meeting the expectations in terms of either vaccination or their immunization or their physical assessment that's required depending on the grade of student, then they're supposed to be excluded from school as of the 30th day. The superintendent does have the authority to extend beyond the 30th day for some window of time. And I would have to defer to CMS about sort of their policies and practice around exclusion. That we don't have the power to exclude school. That is, the enforcement of that is left up to the school. The school nurses do identify students who should be excluded, though, and notifies the school of those students.
And then just the question about the syphilis.
Oh, Bicillin is, it's a supply chain issue with Pfizer, I believe, is the pharmaceutical company that produces Bicillin. I'm looking at Glenda. It's a supply chain issue. It's happened, I think, at least a couple times a year for pretty consistently now. And so we do have an okay supply today, but we are not able to treat non-pregnant women with Bicillin. Bicillin is the easiest way to treat syphilis because it's an injection, not a pill. And so it allows it and makes sure that the person gets treated because people forget to take pills, et cetera. But we're not using it for non-pregnant women right now, only pregnant women because of the shortage.
Okay, thank you.
Yes.
Thank you. Commissioner Powell.
Thank you. I'm going to do the same thing Commissioner Meyer did. I'm just going to say my questions first. So the first question is, you're talking for measles, you're talking about a population of young people, like you were talking about K through 5. And there are many adults that were born who had the measles, mumps, rubella vaccine and need a follow-up vaccine because they had it so long ago. And so can we talk about that population? Is that necessary for any adults to get a follow-up vaccine? Second is you talked about how we still need to work with getting people from smoking. And I don't know if when you're including smoking, are you including vaping? And the county has cessation programs, and I think we need to talk about that a lot. Are they free to the public? My next question is about mental health, the reporting, because I think it's worse than what we're seeing on the graph. And so even as dismal as it is on the graph, I think it's worse than that. What do you think the factors are that are contributing to that? Because, when you see the numbers, and I've been talking to people about this, about suicide ideation, I just think it's worse than what we're seeing. So just more information on what factors do you think are making things worse? How can we help? The fourth question is, does the health department know every patient who has been treated for a sexually transmitted disease or infection? Is that a required reporting from the healthcare systems, or is this just people that we treated? And tuberculosis is different, but it's my understanding that anyone that has a positive PPD has to report to county government that there is somebody that has this so that they can be followed by the public health director to see if it turns out to be a real case of tuberculosis. So, are these numbers the totality of Mecklenburg County or just the people we treat? And that's all for now.
Okay.
Thank you.
All right. Back to measles. So in general, there's not a broad recommendation for boosters for anyone for measles. There are some very narrow groups of folks who in general need to consult with their provider around getting a measles booster. But again, there is no broad recommendation for a booster. So just to be clear, we've gotten a lot of questions about boosters, and in general, that's not needed. If you are immunocompromised or have other complicating health conditions, then your provider may recommend a booster. And then some certain groups, depending on when they were born, and if they got 1 versus 2 shots, that's a narrow group. It's very hard to communicate that, though, and so individuals should check their immunization record and their recommendation with their provider before they would come. They can also come to us, and we're happy to do that with them to make sure if they are eligible or need it, they are, but that's a very narrow group of folks. In terms of smoking, yes, vaping is a part of that equation. There's a lot of science that's coming out now about the health consequences of vaping. There was a big study that just came out in December about the damage that the microparticles in vapes do to lungs, and so we do as well try to message and work against the vaping. And our cessation work is related to us providing basic nicotine replacement therapy, which we do provide at no cost to community providers to distribute. And then we also support the state quit line, which is essentially a line people can call to get connected to services for cessation. The big issue with smoking, though, is that the smoking policy is regulated at the state level and is preempted here locally from us being able to do a lot around smoking. And we got to do something about how tobacco products are accessed in the community if we want to be able to actually make a huge dent on smoking practices. If there is an oversaturation of tobacco products in a community, people are going to use them. And so the reality is, and if there's no regulation on the types of products, which is part of the concern with some of the vapes, the potential dangers to our residents are great, but the state has preempted our ability to take action locally, and so it is something that we have to continue to focus on. I agree with you. Certainly mental health is underreported across the board, and so I think you're right in that in terms of why mental health is a growing issue for us. There are a whole host of factors, Commissioner, that I can really articulate. I think it's been well documented that the social media and external influences is having an impact on youth mental health. The pandemic certainly had an impact on mental health for young people and adults, and so I think it's a combination, as well as, frankly, a lack of investment in the behavioral health system to be able to properly care for people at all levels of care, right? When people have lowest acuity behavioral health, they should be able to access care. And if you can't, it's just going to, just like any other chronic condition, it's just going to keep getting worse, right? And we should be able to help people before they get to a place that they're in an emergency department considering suicide. So, and then yes, this is all of our communicable disease reporting. So any number I provided today is disease counts for the entire community and not just folks that we see in the health department. And so that by law is our responsibility to get reports. Most of those come to us electronically now, thanks to technology, but we still do get faxes that somebody has to monitor every day and key into the system.
Okay.
Thank you.
You're welcome.
We go with SRM, leak, and then YTI.
Let me first say thank you.
Excuse me, Commissioner, I'm sorry. I'm going to go to Commissioner Rodriguez McDowell,
Oh,
and you,
I didn't
then
mean-
YTI.
I'm sorry.
Thank you,
Excuse
Mr.
me, Ms.
Chairman.
McDowell.
Thank you.
Mrs. McDowell.
Thank you. So can you, thanks for, I can't even imagine how you can do all of that. Even just presenting it, I couldn't even read all that stuff. So anyway, thank you for what you're doing and for your whole department showing up here today. That's really awesome. Can you help me understand slides 6 and 7 of the first report of that one, where the relationship between uninsured residents and primary care access, it seems obvious, like if you have more folks who are insured, that, they're going to have primary care access, but these graphs don't really line up,
Sure.
Very well. And so that's one question. And then the part B of that is, what is ours? How do we affect primary care access? Like, I know we have a goal of 16%, but what are the factors that we control that can help bring that number down?
Okay, on the first question, so this is back to Commissioner Griffin's point. Having insurance doesn't mean you go to the doctor. So there are a lot of people who are insured who have not seen their primary care doctor in a long time. And many people with insurance who would say or report to us, I actually don't have a doctor that I regularly get care at. So this is just saying, how many residents report to us that they don't have a doctor that they receive regular care? I dare not do a scan in this room because I know 100% of us have a primary care doctor, but in fact, insurance is just one part of the equation, being able to pay for it. And if you're on Medicaid, you're required by Medicaid policy to be assigned a primary care doctor, but if you don't select one, they just randomly assign one to you. And just because you've been assigned one doesn't mean you actually go. And so that is the really important part of Commissioner Griffin's focus, and what we've been focusing on since I started talking about primary care here, is that if we can get people to engage with primary care, we can keep them out of the emergency department, we can keep them out of urgent cares, which are both way more costly to seek care. And so a couple things I'll say that we do just to keep this brief. First off, our community health workers are a key part of the equation. They are the folks who have this conversation with residents to say, do you have a doctor, right? Like, well, let me see if your insurance has a way for you to get connected to a primary care doctor. Let me help you navigate this really big list of providers. That's probably usually like 200 where you have to go search and say, find a doctor and get someone close to your home. That's a really important part of what we do is providing that resource to connect people to care. And then I would say more substantially, we invest close to $3 million, actually more than $3 million a year in the safety net providers who deliver primary care to anybody regardless of their ability to pay. So those are our FQHCs and our safety net clinics. And so that more than $3 million investment does cover care for a lot of residents in the county, close to 11,000. Are able to seek primary care at that safety net at those safety net providers without cost being a barrier.
So those are considered primary care, like they name who the doctor is at those facilities?
Yeah, so at all our safety net providers, they are specifically providing primary care. Now, the FQHCs also provide wraparound integrated services. So if a patient goes there, they need behavioral health or dental services, the county investment can also support those as well. But those providers are medical homes. They're meant to be a place where folks can seek primary care. And we select them essentially such that these are folks who are already going to serve the uninsured because the cost is not a barrier. Right. So we have to have a safety net in the community, especially when you have such a large number of folks without insurance.
Right. Okay. Thank you.
Sure.
Commissioner Leek.
Let me first say thank you so much for this report. Communication, communication, communication. How do we get this out before the public as we have received it? And the seriousness of it is the change in those who are in leadership in government who's discrediting the need for health care and the quality of those who represent the federal government and dictating what we can do and can't do. How do we handle that? That's number one. Number two, I worry about children and I worry about senior citizens with primary care or with care, period, when it comes to the health of Black people and Black children. What are we doing to increase our knowledge and support in our communities for those individuals? And number three, when we talk about schools, I worry about charter schools, I worry about homeschooling and other means by which children are not in the care of the public system and don't believe in it because of their religion. That's a major issue for us. Again, thank you. Can you answer those three questions?
Yes, ma'am. I'll start with the first one. So as it relates to the federal government, we continue to stay in close contact and communication with the state who sets policy around health for North Carolinians. And so there is a lot of, I would say, noise from Washington as it relates to public health and vaccine policy. And we have been, I would say, as proactive as possible with communicating with our residents about what we believe to be science and data and truth, and trying to ensure that we bring as much clarity to the conversation here locally so folks can get answers to their questions. The state, though, is also doing the same thing, and the state is ensuring that they are continuing to follow good science, even when we're seeing these varying actions from our federal part contend with, and it is something that we're going to have to keep dealing with for several years. And our education strategy is to use the folks that people trust, and that's their neighbors and community health workers, to help us carry that message. In terms of what's happening in charter schools and homeschools, we don't have a lot of visibility in those. We don't provide nursing support to those kids, and so there's not a lot I can tell you about what's happening in those settings because they are separate from our system of care.
My time is up.
Yes, ma'am.
Thank you. So I stop at this point.
Yes, ma'am. Commissioner Townsend Ingram.
I want to say thank you, just like everyone else, about this information. It's overwhelming. It's a lot. So thank you so much for keeping such good information and informing us. I have a few questions, but a couple of them have been knocked off by my colleagues. So I appreciate that. Is there a recommendation for parents who have children with challenged immune systems? I guess, no, let me change my question. If there is a child that has a disease, do the schools report to you, and then are the schools then required to report to the parents or send some kind of notification out of cases of measles or any kind of communicable disease that they have, especially those parents who have children with challenged immune systems? Then with regard to the primary care physicians, do we partner with any organizations to provide information, like on our website or anything like that, about primary care physicians, where they can get one, for instance, like does C.W. Williams? Are they just a clinic, or can they get a primary care physician there? And then I don't know if most people know the cruel irony of Dr. Janelle Green Smith, who was a midwife also and was a staunch advocate for Black maternal health, and the tremendous number of Black women who die from childbirth and then the death of Black children. She died a couple of weeks ago right after giving birth herself. So do we have any programs currently that can speak to the crisis? And is there a threshold that must be reached? For instance, like the opioid epidemic, it reached a threshold and then became a crisis and an emergency. Is there something similar for Black maternal health?
Sure. I'll start at the beginning again. So in general, if an infectious disease is reported to us of any kind that's infectious, our first line of action is to talk to that person to figure out who they may have exposed. Our job is to figure out, as investigators, to figure out who they may have exposed, whether it be a person or at a place, and then to essentially follow up with those people and that place. So whether it's a sexually transmitted infection or it's a respiratory virus like measles, our job is to find all of the exposed folks and tell them they've been exposed and to take action relative to either getting them tested, having them monitor for symptoms, having them quarantined, depending on the disease. So if a child in a school was ever exposed to someone with anything that was infectious, our staff would identify the child. So we had a case of measles a couple summers ago. So the first thing we do is figure out what classroom that child is in, who's in that classroom, what's the roster, what days they were at school, who was at school that day, and we make a list of potential contacts. And that investigation, especially with measles, happens within hours of our notification because we only have 72 hours from the exposure to act. And so our CD nurses, that's their full-time job. Is it looking for who was exposed to something? How do I notify them that they were exposed, and then take action if I need to? For example, with measles, it might be get them vaccinated, or with other issues like HIV, it will be to get a person tested and treated if necessary. And so we also have disease investigation specialists who actually go out and they knock on doors for STDs, and so they find people who've been exposed or people who are doing the exposing and make sure that we are disrupting transmission. MedLink is the organization here that brings together our safety net providers that do primary care. We work very closely with them. Our staff are on the advisory body. And on our website, there is a primary care locator on the county's website that you can find places where you can get care at those safety net providers, as well as at our hospitals, community clinics. And then lastly, maternal mortality is certainly a crisis, especially for Black women in this country. We have been working very closely with our partners. We have a number of programs. I don't have a ton of time to itemize them all, but there is a maternal health summit that we started to co-sponsor with CareRing. We are planning the third iteration of that now, which I would invite you all to participate in. I think some folks have been before, but that is an opportunity for us to bring together every key stakeholder in this community around reproductive health, focused specifically on the disparity between Black women and others as it relates to maternal health. And so I'll defer to that as a time to really talk about that.
Thank you so much. There's a few more details that I wanted to ask, but I'll
Sure.
send an email for that. Thank you.
I'll come back to you in a few minutes, Commissioner. Commissioner Dunlap.
Thank you, Mr. Chair. Real simple. Are we working with our school district with sex education, whatever they call it now, to address the issue of the increase in sexually transmitted diseases? And I'm a little confused about the information about the HIV AIDS. When I thought we were going down in that, the last report said, as of September 2025, there were 205 new HIV infections and 97 cases reported, which I thought was down because in 2024, there were 285 new HIV diagnoses. Anyway, if you could clear that up for me.
Sure.
And then the other thing, and this is kind of interesting, our neighbors to the south of us have different rules as it relates to vaccinations. And when you look at the difference between the cases in North Carolina versus those in our neighbors to the south, significantly difference in terms of the number of cases reported. So what are we doing to increase vaccinations in Mecklenburg County?
Okay. Going back to the top, sex education is not something that we're responsible for or have a role in the school district because of changes that happen in state laws here. And so we don't go in schools and do sex education. So I would defer you to the superintendent to talk about what they're doing around education, sexual health education in the schools, because we are not a part of that in the school district. In terms of HIV data for 2025, it's not whole year data. That was as of September of the year. And so it was just an indication that we are trending in the right direction to be towards decline or at least not growth in 2025, but we haven't closed the year out. So we close out the data at the end of this month for all of 2025. And so we'll be able to provide an update. When you get your December communicable disease report, which I know everybody reads, you'll be able to see sort of where we ended the year out for HIV cases. But I will say, though, 205 new cases a year is still way too many, and 97 cases of AIDS is too many, right? Like, we are making progress, but we've got a long way to go to end the epidemic. And so part of it is that, we got to find all the cases and get people in treatment, which we're doing an excellent job at. But we've got to find all the cases. And, we don't have the ability to force everybody to get tested, which might help us in that. But, we got to get people to voluntarily come get tested. I'm very excited that we're doing some new work. Our HIV division is doing some new work with the hospitals to do opt-in, opt-out testing in our emergency departments. Our state law requires opt-in testing for HIV tests so that instead of when you go to your doctor and get treated, instead of them just routinely checking for HIV, you have to actually sign up for it. And a lot of doctors aren't asking, right? I go get my physical and they don't ask me if I want it, right? And so the best practice is that you have opt-out, meaning that you test everybody. When you draw blood, you automatically test, right? That's how you find cases. And so we were able to get Atrium to agree to do a pilot with us, and they immediately started finding many more cases than they ever had found because we were automatically testing. And so the more we can do that kind of stuff with our providers while we don't have state laws that support the work, work, it will allow us to make more progress here on HIV. And then lastly, I mentioned already, we opened up our vaccine clinics to make appointments available for kids to come in. We had a whole campaign with child care centers to focus on promoting vaccines and making sure child care centers are, because that's when, the kids in child care are the ones you want to get them when they're in child care, not when they get to school. If you're waiting to kindergarten, it's already too late, or later than it's supposed to be. And then the mobile health team is at schools, so they're coordinating with school health. So a school that has high levels of kids without vaccinations, school health is working to send letters home with those kids to get consent. And then if the parent consents, then when the mobile health team is on site, then it can all happen and the parent doesn't have to do anything except sign the consent form. So those are our main strategies right now for trying to increase vaccination rates, in addition to trying to convince families who don't want to do it that it's the right thing to do.
Thank you.
Before we go to Vice Chair Altman, there were two quick follow-ups. Commissioner Leak had a follow-up and Commissioner Townsend Ingram had a follow-up. I ask both of you to be straight to the point, please.
What hospitals provide support for those who are in cannot pay to visit the hospital or have a hospital bill?
Yeah.
Do we have hospitals that take care of our people?
Sure. So both healthcare systems, we only have two systems here, Atrium and Novant. Both systems have both financial assistance programs, as well as they do uncompensated care as a part of those programs. So individuals who cannot afford to pay their bill, they fill out an application and the hospital will write off the bill. Last year, Governor Cooper also made big strides on medical debt by clearing billions of dollars in medical debt for residents across the state, which also was a huge progress for clearing people. People had, things on their houses and things as a result of medical debt. The challenge, Commissioner Leak, though, is people have to know to apply to those programs. So we've been putting a healthy amount of pressure on the health systems to just bring more visibility to the programs, that they exist, so that people, when they get a bill, they can auto-enroll. And that was actually one of the conditions of Governor Cooper's deal with the hospitals, was that they had to auto-enroll people in financial assistance programs if they qualify. So instead of people having to find the program and apply, they have to be proactive in getting people enrolled. And so I hope that that's making progress. I don't have a lot of evidence, but I think that's an important tool.
I want to commend the communications department, but I'd like to make sure that this information we have today and talking with you, sharing with us, will be disseminated within the confines of our community, and especially for our seniors and those who have young babies.
Commissioner,
The health department is, the emergency room is full of children and adults. You go to any hospital, it's full.
Yeah, I meant to mention the Live World Tour again. That is why we're doing the tour, so that we can actually bring all this information as well as resources to you all's districts across the community in person. And it's not just me or anybody talking on the screen. So I look forward to you all participating with us in that.
Thank you, Mr. Chairman,
Thank
for
you.
that.
Commissioner Townsend Ingram.
Yeah, I don't want to take up too much time, but I just think that we need a mindset change. Not to be gross, but when I taught school for 2 years in high school, these kids, they don't think about sex education in the way we used to think about it. It's like, okay, if there's a medicine to cure it, I'm not worried about it. They don't use condoms or whatever. I know that sounds gross, but it's like, it's probably higher, the number of communicable diseases. And not to ask you about things that are not within the jurisdiction of our health department, but my question before was about, if there are cases that we find, is the school responsible, and I don't know if you know this, do you report to that school district that there is a child, and then is the school responsible for saying the Board of County Health has informed us that there are 3 children in this school that may have exposed others to measles?
No.
Does that make sense?
Yep. So the way that works, no, we're responsible for notification and issuing any kind of order. Now, sometimes that does happen through the school nurse or the school administrator, only for convenience purposes. So the communicable disease team will produce the letter, that says your child has been exposed to X condition, you need to do this. Like, let's say it's TB. So we're going to be on site on Thursday for testing for TB. Your child needs to be tested, sign the consent form so your child can get tested. That letter goes to the school nurse and the school administrator. Because nowadays a lot of the communication with parents is electronic, excuse me, the administrator has to issue the notice in the system because we don't have rights in the system. And then they are also able to provide paper copies of it to the family as well. But the electronic is also really important because that sends an email basically to the parent. And so that notification, and we don't talk about the number of people they were exposed to. That's not important. We just basically say, hey, you were exposed to something. Here's what you need to do. Any details about who exposed you, how many people were there, that information is kept confidential.
Gotcha. Thank you.
Vice Chair Altman.
Thank you so much. My first reaction to this is that it all weighs very heavy on my heart. I mean, so much of this is really scary, and I just want to recognize the team. I also have a sense of relief that with limited resources and limited authority, that we do have the A team doing the most good that we can with what we have, and I'm super grateful to all of you. I want to ask about youth suicide and HIV/AIDS. How many, I wonder how many youth, if we can bring up that slide, which is, I'm so glad to see the numbers leveling off, but it's still nonetheless completely horrifying. How many children show some sign, have some distress signal before a completed suicide that can be documented? And the reason why I ask is because I have a friend whose child took his life, who he says was the happiest child on earth, and there was no sign, none whatsoever. And this particular father recommends sort of direct asks to to your child or the youth in your life. And I'm not sure what are the appropriate questions that parents and adults in and around children, are there direct, uncomfortable questions that we should be asking them? What are those best practices? And I don't know if anyone can speak to that, but I would like to hear from, folks who have that expertise. What is good guidance to be more direct so that it's not the case that we can have a child who is having distress, but because we all are really uncomfortable with the subject, that we didn't ask the hard question. My second question is around HIV/AIDS. I'm really shocked by the fact that MSM cases account for nearly 69% of new cases, and I guess you can correct me, but this refers to transmissions of HIV/AIDS where the people involved do not identify themselves as LGBTQ. Is that true?
No.
No. Okay. So if you can explain what MSM means and what is being done to try to reach that community to prevent transmission, since it accounts for such a very large portion of cases.
Sure. All right. So your first question, I don't think there is a one answer to that question, and I'm going to defer to follow up on sort of having someone who has more expertise in this space talk at a later HHS meeting about sort of what the practical guidance is to parents and families. I don't feel positioned to give you that guidance here in this moment, but I will certainly follow up on that. Secondly, as it relates to HIV, so the MSM bucket here is individuals who report, men who report having sex with other men. It's not about their sexuality identification. That's not something that we get involved in. That's sort of their own identity and their decisions and not relevant. This is about sort of the mode of transmission. So it could be a combination of homosexual men, bisexual men, those who don't identify as either of those, but it's the matter that they're men that are having sex with men who fall in this. And these are folks who report that activity to us, and it doesn't mean that it's exclusively men who have sex with men. It could be, like I said, bisexual men as well. And then you'll see the smaller blue slither there is where we have individuals who are MSM, and they also have injection drug use, which of course is a group that is also concerning as well when it comes to bloodborne pathogen like HIV.
Well, yeah, thank you, sir. I guess my question is,
you asked me to.
I feel like there's a lot of great outreach to the LGBTQ community, you know, but is there a significant amount of transmission that we are not reaching that education and those resources because they may not be a part of those social circles?
Sure, yeah, absolutely.
And if so, like, what are those methods of trying to reach those communities and getting them resources?
Yeah, so the most useful thing that we use, obviously, is dating apps. And so we use dating apps because that is commonly where you're basically asking me for, people who don't want to be found, how do we find them? And the reality is, Commissioner Altman, that is a challenge, right? We don't have a roster or a registry. And so the most effective tool we have is obviously if someone's in our care in the clinic, we can educate in person. And so that happens very often. And then outside of that, for general outreach, is using the dating apps are an opportunity for us to provide campaigns and education where people are seeking, sexual activity. And so we use them all. We use the ones that we know people are using, and we promote on there just like you have Google Ads. We promote on there as well. Both testing resources, our Let's Get Checked kits are posted there so folks can access those easily, as well as just awareness about it. So that's one of the things that we have. Outside of that, we do try to meet people where they are, so we go to social places where we know folks are going to be, but that, to your point, is very difficult. If you are, as folks call them, down low men, like you're not trying to be found. So the reality is that we are using what we have, but that's limited.
Thank you for the presentation. Certainly want to say thank you to the entire team for all of your work and what you all do on a daily basis. Can we go to the slide that Commissioner Altman referenced earlier? There's a couple points that I want to make. It was the suicide.
Oh, okay.
There we go. So, Dr. Washington, when we have a goal of 185, I mean, obviously as a community, we want that to be zero. Certainly there's a goal, and I know this board is certainly moving to goals. Where I'm conflicted with some of our goals is the fact that I'm not so sure. I feel like there are so many variables that are out of our control that to put a number on some of this is an interesting way to approach it. For the simple fact, we have 160 people a day moving into this region. That number is going to continue to grow over time. It has grown over time. The more people we have coming in to drive that number down, with everything that we're doing, I wonder, and again, not just with respect to this, but I'm always conflicted about what our role is as government, but what society's role is, what parents and guardians' roles are in this equation. We continue to pile on our staff. You're not doing enough, you're not doing enough, you got to do this, you got to do that. Every way that we can communicate information is communicated in so many different lines of business or function. Every way that you can imagine. Social media. Then somebody says, oh, you got to do a newspaper. Oh, then you got to put a mailer in. And then, oh, you got to do this. And we do it all. But I just wonder if there's a limit to where our responsibility, when we have done and are doing what we need to do and continue to do that, but where's the accountability on the other end? When you have messages coming from the federal government that have a tremendous amount of resources, but then we're being asked to match those resources, match those messages, and we're just outmanned and outgunned. I'm not saying to give up or lay down, but I'm just not sure I'm comfortable with the way sometimes we're reflecting. While I appreciate having goals, but I'm not sure I'm comfortable with the way we reflect, because I don't think it's reflective. I don't think the outcomes are reflective of the effort.
Sure. if I could just say, usually if it has Live Well Mech on it, this is about everybody. So the accountability here to these goals are set. These targets are set in partnership with our healthcare systems, the steering committee for Live Well Mech. So this is not you guys are asking me what the county's doing, and I'm telling you what the county's doing. But really, this is a part of the bigger we. Like these, which is why I'm always very clear about the scorecard. Commissioner Griffin is requesting that this scorecard is about this community and not about Mecklenburg County explicitly, Mecklenburg County government explicitly. And our hospitals have a role in this. Our school district has a role in this. And those bodies are represented on the Live Well Steering Committee. And their improvement plans marry ours or partners to ours that outline what we can do as a county, but they have a stronger, in some ways, role to play because they are delivering the vast majority of healthcare to our residents, right? It's been delivered by both of the two systems. And so this discussion, this report, this update is not exclusive to what Mecklenburg County should be doing. It should help inform our investments as a county and what we do, but the work here is about everybody in the ecosystem that's public health and healthcare in Mecklenburg County.
That's helpful. To me, there's a sense, and it's probably just me, but there's a sense that we own this, right? That this is Mecklenburg County that owns it, not necessarily community and their partners. So thank you for that clarification. But the last point that I would just make is, when you just take the unvaxxed, let's say, we know that we had 5,000 that just presented themselves in the school system. But if you extrapolate that number to the broader community that we're not tracking, you know that number is north of 5,000. Those are just children, right? And so those are folks that probably are not getting mental health services or, dialing into mental health services or other sorts of care, whether it's physical or behavioral health. So again, I just want to double down on the point that I think there's always room for improvement. But I'd be remiss if I didn't double down on the fact that there are variables that are out of our control, and that there is a component where I believe that there has to be some level of responsibility that goes beyond government interfering in the lives of people. So I'll just leave it at that and say thank you very much. And with that, we can go to the next one. And before you go to the proposed health rules, we're all familiar with how this works, with the exception of Commissioner Townsend Ingram. So unless there's going to be a burning question, we don't need comments. Just if there's a specific question to a rule, I'll go to that person. But Commissioner Townsend Ingram is the only one that's not familiar with when we do this.
All right, and let me also just take a moment of personal privilege and thank Dr. Scott, who just walked out, who leads this entire prior presentation and the work that we do there, and her team and all of the team that's here. Our environmental health team is here, and our attorneys here, Jennifer Patterson, Crystal Swinger, our environmental health director, and some of our leaders are here to support. All the rules that I'm going to talk about today are in the environmental health space, so let me also just say thanks to them. Okay, so as the chairman just said, you all hold the power to pass Board of Health rules. They apply throughout the entire county, including the municipalities and the unincorporated areas. They're adopted by the board as you act as the Consolidated Human Services Agency and with the authority of the Board of Health in Mecklenburg County. They do have the force of law. There are 3 mechanisms of enforcement: criminal, civil, or administrative penalties that can exist in any of the rules as outlined in the rule. In order for us to adopt, amend, or to repeal a rule, you all have to approve it, but we also have to notice it in the local newspaper for public comment, and so there's a 10-day notice requirement, which is why I'm here today to talk about the proposed changes, but they will go on your agenda, and then the county attorney's office will notice them appropriately before they'll become law. All right, so there's 3 actions that we are proposing. These are highly technical. So there really is a lot of detail. There's a lovely binder in front of you. In that binder is a copy of the existing rule. Is a copy of the red line version of the rule, a clean copy of the final rule for each of the rules that we're proposing. If you flip through, you can see that, again, these are very technical rules, and these changes are mostly in order to comply with state laws, we need to make these changes that are proposed here. I'm happy to answer burning questions or pass it to Crystal to answer burning questions, but I'll talk through them really quickly. So we're requesting to repeal one rule and amend two rules. The first rule is on repeal, which is the residential swimming pool rules. We adopted these rules in 1999, and we amended them most recently in 2023. And the point was to essentially establish safety standards for our residential swimming pools. The state requires us to inspect public pools, but there are not state standards for residential pools for inspections. The state the General Assembly passed legislation last year that basically removed our authority as a local government to adopt rules related to residential swimming pools. Our belief is that this was tied to some of the concerns around people renting out their pools, and so we no longer have the authority to inspect residential pools. It's not, in my opinion, good public health practice, but it's now law in North Carolina, so we have to repeal our local rule because it's against the law. As simple as that. The second amendment is, so that's the repeal. The amendment is around child care, daycare homes, and family care homes. This rule was also adopted in 1999, was most recently amended back in 2023 when I came to you guys with a lot of rules we had to update. This rule establishes minimum health standards for family child care homes, so people who are caring for kids in their home that are not covered by the state's sanitation regulations. We require locally in Mecklenburg an annual operating permit to ensure that if you're going to be having a child care in your home, that you are a child care program in your home, that it's safe for those kids. Most of the amendments are around changing the name from child daycare homes to family child care homes because that is the terminology that's used by the state child development and early education team, so that there's so there's alignment between our local rule and the state rule, and it will minimize confusion for families. So very minimal technical change there to those rules. There are some additional amendments that the team has proposed as well that are more technical, updated definition for what child care to align with the state standards. Remove the enforcement of building code and zoning requirements because that is not something that we have the power to enforce. Though it was in the rule in 1999, we don't have any authority around code and zoning, and so that is not something that we can even respond to. And then it removes the requirements related to the swimming pools on the property because we no longer can regulate swimming pools in any rule. And so that authority is taken away from us as local government, so we have to take it out of the rule for childcare homes as well. Also updating sanitation requirements to make them more closely aligned to what we expect for child care centers. So this is making them a little bit more stringent, but to make them, again, this is about protecting the safety of young kids. And then we're adding some personnel, health, safety, and hygiene requirements, again, so that the child care day homes, the family child care homes the rules are almost the same as what they are for licensed child care centers around how their staff are maintaining health and hygiene. And then adding the authority for the health directors to suspend or revoke a permit if you don't apply with the rules. So that's an enforcement tool that is lacking from this rule that we're proposing to add. And that's it for the changes to the family care, child care home rules. Again, they're all itemized in the binder in front of you. All right, next, the groundwater rules are really long and really complicated. And so these were originally adopted in 2004. We most recently amended them in 2011. These require residents in the county to register, permit, and monitor their wells, certain types of wells. We have private drinking water wells, and then we have wells that don't supply drinking water supply. Things like irrigation and other monitoring wells that might be in on people's properties. We are proposing to divide the two rules into two separate rules so that they're not in one rule. Right now, drinking water and the others are in one rule, and we would like to divide them to have two separate rules to govern drinking water wells and one rule to govern other types of wells, mostly because the General Assembly is really focused on well monitoring and permitting in counties, and we are anticipating additional loosening of restrictions in the state of North Carolina that will impact these rules, that we might have to repeal one or the other. And so we're trying to just anticipate the changes that we need to make so that we won't have to repeal the entire rule, and we'll still be able to govern at least over the wells that are used for drinking. And so there's an effort, and there has been a push to privatize this work so that government's not a part of the process, which of course most in public health have concerns about. But we are just trying to make sure our local rules are well positioned if that does happen. There are also a few other technical, several other technical modifications. There are some statutory references that have to be updated to refer to the right general statute. We also need to add an appeals procedure to these so that it can be consistent with the state statute, and then clarify that these are Board of Health rules and not local ordinance or regulations. When our rules were first written, sometimes they were intermingling language around ordinance, regulation, Board of Health rule. So we just need to be explicitly clear that this is a Board of Health rule, not a local regulation or ordinance. On the private drinking water side, again, we're going to adopt the state's well construction standards, as well as adding an area of regulated groundwater usage review. Again, this is just a technical thing that the team will need to do, and it will be required. It will require them to essentially record with the Register of Deeds prior to getting a well permit being issued to them. So, and then there are several other, on the wells for other than drinking water, there are proposed amendments around the construction standards similar to what we were proposing for the drinking water wells. And then we're proposing to eliminate the exemption for sites designated at high risk for monitoring well payments. And again, this is essentially sites that are deemed orphan sites can still be exempted if the monitoring wells are installed to determine the responsible party for contamination. So this would essentially remove the exemption that's for high-risk sites, and then give that one carve-out for the orphan sites for environmental health. And that's it. This is probably the simplest description of the changes. You will see a lot of red lines in the rules. And again, as the chair said, I'm happy with the environmental health team is happy to answer any technical questions folks have before the rules are proposed and go on your consent agenda. And I see Commissioner Altman has her hand up, so I'm happy to take questions. But again, they will be presented on the consent agenda, and you guys have as much time as you need to ask us questions that are technical as you review the amendments. So you need to properly take a look at the amendments, and then environmental health will be available to answer questions as needed.
Vice Chair Altman and Commissioner Powell.
So I'm clear. All of these changes are being updated as dictated by the General Assembly, is that right? And do we have any authority not to do them? No, the attorney's saying no. So understanding that, so I'm clear, are the top three that you think may be inimical to the well-being of the community? Like, I want to know what I am required to approve, which is not good for the community, because I think it's terrible to be put in a position to have to pass something if you don't think it's in the best interest of public health. I'm really troubled by this.
I don't think there are any I think the well rules we think will actually help. So the amendments that we're making, the point I was making about splitting the rules, the concern there is that we're anticipating legislation in the future. So we're just trying to posture our rules so that we don't have to repeal an entire rule later on. So there's nothing there that's a threat to public health or a concern. I think the same is true for the family child care homes. We think we're making things better with these amendments. The one that is concerning for public health is the residential swimming pool permitting process, because now we won't have any involvement in permitting residential pools in people's homes. And so
even if it's like Airbnb?
Any residential pool at all. So if they don't have appropriate safeguards, or they don't have appropriate distancing from the door, or if they don't have a gate when they need to have a gate or a fence to keep people from being able to go and drown in the pool, if the water quality is not being properly maintained, there's a whole host of things that could be impactful if people just build pools without any regulation in their backyards. And so, but unfortunately, the General Assembly has taken this action, and so we can no longer regulate. And if you have, I'm happy to call up the team. You want to know kind of more about what happens in the inspection process.
Well, no, but what I'm hearing you say is actually you don't have a concern from a public health standpoint for any of these changes except this one with residential swimming pools. Is that right?
Yes.
Okay.
I'm looking at Crystal to make sure she agrees with me.
All right. No, that's helpful. Thank you for plowing through all of that and summarizing it that way. Thank you.
Commissioner Powell.
Thank you. And I'm really glad the environmental health team is here so we can all look at them and thank them for the work they do, because this is really important. And I feel like I also need a hydrogeologist here.
Well, don't ask the question.
I think what I need to do, because I have so many questions, in my district, Commissioner Leake's district, and probably throughout the entire county, there are former Superfund sites, brownfields, so many wells that, a lot of people are connected to city water and they don't think of the wells. So I feel like what I need, instead of asking questions now, is I would like to request a meeting with environmental health to go over the well part. I need more than 10 minutes or 3 minutes. I just need much more time. So if I could request that, we can set it up.
Sure. And they are scheduled to present at an upcoming Health and Human Services meeting this calendar year, but we certainly can get that scheduled sooner if you would like.
I would like to do that before we vote on it.
Sure, absolutely.
Thank you.
Yes, ma'am.
Thank you, Commissioner. Right, there are no other questions. Dr. Washington, thank you so much. We really appreciate it.
Thank you.
And to the entire team.
Chair, that concludes the two items that you have on your public agenda.
All right, next on the agenda, we have Commissioner reports. I will start with Commissioner Rodriguez-McDowell.
No report.
Commissioner Dunlap.
No report.
Commissioner Leake.
No report.
Commissioner Griffin.
No report, sir.
Commissioner Powell.
No report.
Commissioner Townsend Ingram. Vice Chair Altman.
No report.
All right, and I do not have a report either, and so the last item on the agenda is going to be a closed session item that we have to take care of. And so with that being said, I'll entertain a motion to go into closed session.
So moved.
Second.
Entertain a motion to go into closed session for a personnel matter. Thank you,
So
Mr.
moved.
Attorney.
Second.
Moved and seconded. All those in favor say aye.
Aye.
Ayes have it. We'll,
Chair, I have a clarifying
Folks.
question. Do we have to come back out of closed session?
Yes, afterwards.
Okay, just wanted to make sure for everybody.
they're all making their way.